Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host. I'm grateful to be here. And if you don't know me, I'm a filmmaker, writer. I've been working with CCF for 10 years to create various formats and forms of video content, sometimes live video series like this, sometimes produced videos, all with the same mission in mind, and that is to educate people and raise awareness about neuroendocrine tumors. I've been doing that a long time. CCF has been doing that even longer. So if you're new to the show, we like to, say hello to the community, tell people where you're signing on from in the world. If you're a regular, like I see some that we already have in the room, you know the drill. Say hello, tell us where you're from. I already see Louisiana in the building. And one of my favorite things about the show is how far these programs reach, even live. I say it every week, and I'll never stop saying it. Hi, Rain and Dr. Ramirez. Thanks in advance for the education today. Hey, that's all on our guest today. I'm just here to, keep things moving along, maybe make you laugh a couple of times. Before we get started, we always want to thank Ipsen Biopharmaceuticals for their sponsorship, their support of Lunch with the Experts. We wouldn't be able to do this show without them. And we always have this disclaimer at the top of the program, and that is the opinions expressed by the guest presenters, as well as the questions asked by you all, the audience at home, haven't been created or suggested by the sponsors of Lunch with the Experts. And CCF doesn't endorse or promote any of those views, opinions, or information that will be provided in the presentation. Audience members should not rely solely on the opinions or information expressed by the guest and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. Again, I say this every week too, that last line is really the takeaway. We're going to give you some answers to your questions. We're going to give you some good general advice, but we don't know your specific case. So by all means, take those answers, take that general advice back to your home team, which does, and make the best plan and path for you moving forward. As we all know, each case of this disease is unique, and that means each path forward is as well. So today, I'm really excited to welcome a friend of the foundation, a friend of mine, Dr. Robert Ramirez. Dr. Ramirez, good to see you again, and welcome back to the show.
Great to be back. Glad to see you, Ray.
Thank you. Likewise. Normally, things have changed. Dr. Ramirez has a new role and a new location, but normally he's always there in the Lunch with the Experts comments thread, chiming in when we need saving sometimes. And I always kind of call him the Phantom of the Opera up there, lurking in the by the organ pipes and watching the show. But we're glad to have him front and center today. Dr. Ramirez, for those who don't know you, and also for those who do, who may not know your new role, fill us in a little bit about where you're working now and what you're doing there.
Yeah, so I'm a thoracic medical oncologist at Vanderbilt University Medical Center in Nashville. I've been here, I guess, since about April, and primarily see patients with neuroendocrine tumors of all types, but specifically of the lungs. And I also see everything else related to lung cancer.
Okay.
So prior to that, as you know, I was in New Orleans at the NANETS group, and I was there for about 9 years, sort of in a similar role. But moved up here primarily to get closer to family, which has been great.
Awesome.
And as you know, they already had an existing multidisciplinary tumor program with Dr. Nanu Das, who's been a great partner. And so we're really trying to expand our role here in the thoracic space with more and more clinical trials, and so I think there's a lot that's coming, and it's an exciting place to be.
Awesome, that's great to hear. I can't wait to find out more. Real quick question: you had mentioned other neuroendocrine tumors other than thoracic. Are you able and willing to take other questions, or should we stay specifically in lung nets today?
Yeah, I will attempt to answer any question that comes along. I think obviously for the past 9 years, I was seeing everything neuroendocrine. But now I'm sort of, I still see everything neuroendocrine. I just saw a small bowel tumor 30 minutes ago. So,
Yeah.
so I still see everything, but my focus is narrowing a little bit.
So folks, you're really going to get the most value, I think, out of Dr. Ramirez's specialty, because we get a lot of lung net questions every week, but not, every neuroendocrine expert can't necessarily address those questions. I think that's going to get, most of your value. But as, Dr. Ramirez just said, you certainly can't ask any other net related questions and he will try to field them. But I think that's going to be our unique opportunity today, because lung nets are obviously a net, but they have kind of their own thing going on there. So, and I know we get a lot of questions about those. And Dr. Ramirez, back to where you have worked for the past 9 years and for the past 6 months, like 2 amazing institutions. So I think that says a lot about you. But also that's got to be exciting for you, because they're both so reputable. So I think that's really awesome that you've spent time in both of them. I mentioned earlier, folks, about the reach that this program has, and so I'd be remiss if I didn't call out Agnieszka from Warsaw, Poland. See what I was talking about? Pretty awesome. Okay, so folks, here's the show. Go ahead and start sending in your questions. We have great numbers already because we have a great guest. Go ahead and start sending in your questions. We're going to try our best to get to all of them, but inevitably we can't get to all of them because sometimes there are hundreds. So if we don't get to your question, follow up with CCF either here on the Facebook page or at carcinoid.org. But if you're still on the show and stay on the show and you have a follow-up question, keep trying to ask it. Listen, I see a lot of questions. So if I don't get to yours, you can try to ask it again. But one thing that will help me is if you see a question someone else has had or that you want the answer to, or you're also interested in, you can, right under the comment there in the sidebar, there's a like button. You can also there's love. There's a bunch of different emotions you can choose, but they all work the same way for me, which is to effectively upvote that question so that I know that there's a demand for it, and I'll make sure to get it across. And also, if you know someone that should be here right now, especially knowing what our guest specializes in today, tag them in the comments. Let's try to get them here. This show will live here. It'll be evergreen. You can always watch it later, or someone who missed it can watch it. Starting on Monday, we republish it to YouTube. So even if they don't have Facebook, they can watch it later on the replay. But I think the real value is this interactive one-on-one session. So if you know someone that should be here, maybe has a question, maybe they've been struggling with something, go ahead and tag them in the comments or share the video and let them know that this is going on so we can try to get them that help. All right, go ahead and start sending in your questions. Dr. Ramirez, my first question for you is, how have things changed at the new location? Are you doing, different role, or are you building, a program there? What's different about your new role?
Yeah, I think it was a great question. I mean, as I mentioned before, it was the location was chosen primarily to be closer to family. But I had such a niche specialty in New Orleans, I needed to be at a center that would support that. So the options I had were either to join an established program that would help with that, or join a program where I would have to build that myself. I chose the easier route. And it's been great. And so I work with a whole team. I've got a whole team that are specifically focused on neuroendocrine tumors. And we meet as part of a group to discuss research projects, and we have our multidisciplinary tumor boards, and so there's lots and lots of ideas floating around and lots of support. So that's sort of been one of the biggest changes, is how much support we have and how much we can really help our patients through their journey. It's certainly different. I miss Louisiana and a lot, and there's lots of things that we miss. Go Saints this weekend as they play here in Nashville. But yeah, it's been really great. And I'll just add on. I mean, you've known me for a while. I think and patients, they should be aware if there's questions that we don't get to today, please feel free to email me. This is, these are things that can be answered offline. Again, some of the case specific things I can't answer, but my email is robert.ramirez@vumc.org.
Awesome. I appreciate that. And yeah, most of our guests, most of our doctors and experts extend that as well. And so this is, this is what I love, folks, about the NET community is everyone's in here to help each other. Everyone's door is open. So take Dr. Ramirez up on that offer as he so graciously gave us. I want to give a special shout out to Terry, first time listening. Thanks for joining us, Terry. And I will say, and this isn't necessarily to toot our own horn, but from direct feedback, that joining every week, if you can, remember, you can replay these videos, and we have a whole database of videos about this disease that you can access at any time. But those that keep coming back really learn a lot about their journey. And so I welcome you, and I encourage you to tune in for the whole show and come back. We're here every Thursday. We got some holidays coming up, but we're here pretty much every Thursday. And we just got an extension for about another year. So we'll be here for a while. Dr. Ramirez, we've got questions rolling in already, but before we get started, I just want to lay a little bit of groundwork about lung nets, because it does kind of fit in this weird, like it overlaps with lung cancer and it overlaps with neuroendocrine tumors. Can you give us just kind of the foundational information about how lung nets are different, how you look at them and view them differently?
Yeah, so
I know that's
yeah, lung nets are relatively uncommon. I mean, not in my world, but right. They're uncommon. When we talk about lung cancer, very, very common disease. So well over 200,000 people get diagnosed with lung cancer every year in this country. So huge burden of cancer. When it comes to the lung nets, the typical and atypical carcinoid tumors, they represent about 2% of that population. So nonetheless, it's still a significant number when you look at 2% of 200,000. So sure. When it comes to neuroendocrine tumors, those types of cancers primarily, most of the time, start out somewhere below the diaphragm. So in the GI tract, pancreas, but up to a quarter of the time they start out in the lungs. So it's a significant number. So 25% of the neuroendocrine tumors arise from the lung. So despite that, we're still sort of on the back burner as far as treatment. The one FDA approved treatment that we have is a pill called everolimus. But we're learning more and more about just how to manage this disease. And I think, as we move forward, the trials are going to start including more and more of the lung nets. So it's an exciting time. I think it's sort of been underrepresented in the trial populations, not only in the lung cancer community, in the thoracic oncology doctors, but sometimes in the neuroendocrine world as well. So I think we're getting better. I think even we had our national meeting, annual meeting last weekend for the NANETS, which is a North American Neuroendocrine Tumor Society, and in one of the major presentations was in lung nets. Actually, Dr. Diane Reedy from Memorial presented this data and did a great job on this trial and shows that lanreotide is beneficial in these patients. So it took a long time for this trial to get completed or get to the point where they said we're going to stop it and analyze all the data, but it sort of confirms our notion that yes, there is a role for this drug. So I think there's more and more of these trials coming along. So stay tuned.
That's great to hear, and definitely a shout out to Dr. Diane Reedy. She has been on the show. She's amazing. That's all I need to say. Really think a lot of her. So, Dr. Ramirez, we have a lot of questions coming in. I'm going to go ahead and start taking some of them. The first comes from Florian, our friend from Germany. Florian says, my mother is a lung net. She has carcinoid syndrome and leaky heart valves, but normal serotonin levels. Can other hormones other than serotonin also be responsible for this in lung nets? And if so, can these hormones get blocked?
So I think some of the hormones that we think about in lung nets, every now and again we think serotonin, sometimes we think histamine. There's other ones. ACTH can happen. There's others. Now, when it comes down to valvular abnormalities, these are they don't have to, they can be mutually exclusive. So you can have a valvular abnormality and not have a syndrome. So I think if the valvular abnormality is bad enough, we fix the valve. And nowadays, a valve replacement is not generally a major procedure to do, but it does certainly help out with many of the symptoms.
And a follow-up question, what drugs, if any, can be used to prevent growth and metastasis in lung nets without somatostatin receptors?
So great question. So the majority of neuroendocrine tumors have somatostatin receptors. Okay, so based on that, we say, all right, well, if you have somatostatin receptors, you may benefit from a somatostatin analog. So things like lanreotide or octreotide. Furthermore, we can use peptide receptor radionuclide therapy for patients with somatostatin receptors. So that's one of the first things that we look for on our patients. So if we have a functional image such as a dotatate PET-CT or an Octrea scan that shows uptake, says, all right, you have receptors. These are two possible options for treatment. Every now and again, we run into patients who do not have receptors. Okay, so that takes those options generally off the table. Okay, but that doesn't mean we don't have other options for treatment. So everolimus is an option for lung nets, as I just mentioned. There's combination chemotherapy sometimes. With capecitabine and temozolomide, I think there's more and more data with that. There's a drug that is that's coming. It's with the FDA right now called surufatinib, which has data in lung nets and also GI and pancreas nets. So we're excited about that coming. There's other agents that are going to be coming. There's several clinical trials that are available at our center and other centers. So I think there's a host of things that we could consider.
Awesome. Thank you for that. And thanks, Florian. Good to see you again, my friend. Next question from Karen. We're moving out of the lungs for a second. What is the best way to discover a bowel tumor? Is it a colonoscopy or a pill cam? And could you establish what a pill cam is, if you don't mind?
Yeah. So to answer that question, it depends on where the tumor is. Okay, so if it's in the colon, generally colonoscopy will pick it up. Now many of the small bowel tumors, they occur in an area of the small intestine called the terminal ileum. So that can sometimes be reached by colonoscopy. So they take that camera around and they can stick it right into that last part, or that last part of the small intestine, and see this area. So, but sometimes you can't. Sometimes you can pick this up on a CT where you can see an abnormality there. But a pill camera is exactly that. It's a tiny pill with cameras inside, and you swallow it, and it can take pictures as it travels through the GI tract. There's another type of procedure called a push enteroscopy, where it's sort of a longer scope, either from above or below. So you've got to be at a specialized center to do that. But there's different ways to do this. Sometimes they find it at the time of surgery, where they open up and they can actually feel the small intestine until they find the tumor.
Got it. Thank you. And thanks for your question. Next question from Kimmy. Kimmy says, why does it always sound worse or surgery or that surgery isn't likely when metastasized to lymph nodes? Does this mean it's most likely travel to other organs even if it's not seen yet? And how could you tell how long you've had a lung net if there are no symptoms present?
So very good
Okay.
questions. So in a lung net, so what we think about with the spread of cancer usually is that when cancer spread, they spread to the lymph nodes first. So when we take out a tumor in the lung, and whether this is a carcinoid or a non-small cell adeno or squamous cell, we always take out the lymph nodes, and there are certain orders of lymph nodes. So we call them N1, N2, and N3. So they spread to the N1 nodes first. That's the first place they get to. So we take those out, and sometimes if it's a non-small cell, we give chemotherapy afterwards to try to kill anything else off. So if it is a carcinoid tumor, there's not a role for any of that chemotherapy afterwards. We just don't have data showing that that's beneficial. So yeah, that is generally the way cancers spread. It will spread to the lymph nodes first, and it just tells us, it gives us an idea that yes, this tumor is trying to spread. And if we may notice this somewhere else down the line, we don't know, but that's why we continue this surveillance for a long time, even after you've had the tumor taken out and rendered no evidence of disease.
Got it. Thank you. Thanks, Kimmy. Next question from Effie. Hello, Effie. Good to see your name again. What do you think is the best way to manage a DIPNECH patient? What treatment options do you feel is the most effective? And so I'll add on to that. Like what things do you have to view and think of to answer those questions?
Mm-hmm. Yeah. So thanks for that question. DIPNECH is a pretty misunderstood entity, and we tend to think of this as a pre-malignant condition. So if you think, this is a relatively, when I say relatively new entity, it was first described actually in the early 90s, and was found in patients with pulmonary nodules and in sometimes symptoms of shortness of breath and cough and wheeze. And what they found was is an overgrowth of the neuroendocrine cells of the lung. So since that time, there's been multiple series of patients. There haven't been any actual clinical trials based on this because it's such a small population. We're actually looking at our numbers here as well and seeing what we may be able to come up with. So generally with this disease, patients will be sometimes misdiagnosed for many years, and they present with generally cough or wheeze or shortness of breath, and get diagnosed with asthma or COPD or allergies, or and by the time they scans are done and a biopsy is done that shows this, well, the patients have already been on many different inhalers and steroid treatments and lots of other things. So there's different ways that we can approach this. And it really depends on the symptoms of the disease. Sometimes we can watch this, because if we say this is a pre-malignant condition, we think, well, this can turn into a type of cancer. And if it does, well, then obviously if we catch it early, sometimes we can take it out and help out. But so at the bare minimum, we watch it, okay, and watch with scans. And sometimes people don't need treatment. Sometimes symptoms are not bad enough where we think treatment is indicated. But sometimes we think, all right, well, maybe if someone's coming in with cough and it's very significant and throughout the day, and they go to the grocery store and everybody thinks they have COVID and giving them dirty looks, and this is the time to treat. And generally what we start out with is the somatostatin analogs, so either lanreotide or octreotide. They both have some data with this showing an improvement in symptoms, so symptoms of cough. But recently, there was a study that also looked at how patients' pulmonary function tests do with the somatostatin analogs. And it turns out there is some improvement in the PFTs after starting a somatostatin analog. So I think it helps with subjectively with the cough, but also we can quantify this with the pulmonary function testing. So generally, the SSAs are the first step that we go with. There's other series. There's other scattered reports about lung transplant as well. Now, again, this is someone who is very severely affected with this, but these continue to be options. So we co-manage this with our pulmonary colleagues.
Got it. Thank you. And thanks for your question, Effie. Folks, you joined us a little bit late. This is Luncheon with the Experts, a Carcinoid Cancer Foundation program. And today our guest is Dr. Robert Ramirez, currently of Vanderbilt in Nashville, previously of the NANETS program in Ochsner in New Orleans. So I think he has just dedicated his career to working in the coolest cities in the country. Can't wait to see where he goes next. Let's keep the questions coming.
Key West.
What's that?
Key West.
Key West.
It's retirement.
I love it. Here's a question from Wanda. How often do you see or know of siblings, both with primary lung nets, one with metastasis, one without, one with complications, one with no evidence of disease post-op?
Yeah, it's not common. So it's every now and again this can be a familial syndrome. So we have something called MEN, multiple endocrine neoplasia, type 1 and type 4. We would see these lung tumors, and with that, it may be worthwhile. If you have, obviously this is an uncommon disease. So you see this in multiple family members, you start thinking, well, maybe there's a genetic syndrome associated with this. And so that's where I would consider that testing and referral to a genetic counselor. And just as a side note, Rain, I think sometimes people misunderstand what I do as well. As a medical oncologist, I sort of oversee the totality of care, but I work with lots of colleagues that do surgery or do pulmonary or radiation or nuclear medicine. So we all work as part of a team. So
yep.
So I don't do any operations. I'm not a surgeon. So just I know sometimes that's a misconception. I don't do biopsies. I send patients for biopsies. I don't do bronchoscopies. So, but they're all, my team members that I send you to, I trust significantly. So just so, and they're all very good. I don't have anyone that I work with that I wouldn't send a family member to.
Mm-hmm. Yeah, we talk a lot about on the show, as you well know, the importance of a multidisciplinary approach and team, especially with this disease. I'd argue with any disease, but especially with this one where it can, each case can be so unique. Moving on, a question from RM. RM says, what can you tell us about the prognosis for NET patients with a Ki-67 of 30%? It seems like most of what I can find only applies to lower grade 1 and 2 patients, but I'm having a hard time finding that information for this low end of the grade 3. Any advice for RM?
Yeah, so it's a great question. So some of it depends on where the primary tumor is located. Some of it depends on the burden of disease. So, for instance, what I mean by that is if there's a lung net or a pancreas net or a small bowel net with a solitary liver metastasis, that shows a KI of 30%, that's going to be much different than someone who has 90% of their liver replaced by tumor with a KI of 30%. So it's that bulk of disease. And what the other thing that's interesting about that is sometimes it depends on where you put the needle. So you may put a needle in a solitary liver metastasis and get a KI of 30%, but you put it in somewhere else, it may be less, it may be more. So there's these tumors are heterogeneous. So I think it's hard to answer that question without having the patient sitting in front of you and actually looking at scans and in that volume of disease. And realistically, some of it depends on how much, where you're at, what you're going to respond to with treatment. I never put a prognosis on patients and give them a time frame. It's just I'm notoriously bad at that, unless it's eminent within a matter of days. I think most of us can pick that up, but yeah, I think everybody's got their own timeline, and it's not up to me to decide that.
Fair point. Next question from Tyler says, if you have a small lung nodule, is surgery always the best option? What other options are available? Should you have your hormones monitored? If so, which ones? Is there anything developed that you could take to better your odds of reoccurring? And I know you just established you're not a surgeon, but what thoughts do you have for Tyler? Because it's kind of an overall question he's asking.
Yeah, so lung nodules can be many different things. So they're not necessarily cancer. And we see that a lot of times. So I mean, if this is a confirmed diagnosis of a carcinoid tumor, yeah, generally the best treatment is to take it out. Okay. Because we don't know how this will behave. And I've seen patients with small lung nodules that were just monitored and said, all right, let's see how this goes after knowing this is a cancer. So and have disaster happen, within a few years, because as I mentioned, these are cancers, and cancers have the ability to grow and spread and cause lots of problems. So yeah, when we can take them out, we take them out if it's a cancer. Now, patients who do not want them taken out, or are not candidates to have them taken out because of poor lung function, or these being in a bad location, or other comorbidities rather, then sometimes we'll use a very focused radiation to that area to try to kill that particular tumor off. It's a type of therapy called stereotactic body radiotherapy, or SBRT.
Got it. Thank you very much. Got a question about scans. Anna says, my question is about the gallium-68 scan. The cancer has to have transmitters before it can light up, or the light up can come from inflammation also? And maybe she means receptors.
Yeah. So not everything. So sometimes we get fooled with this as well. So the dotatate scans are very, very good. We've got two of them in the U.S. The gallium-68 and the copper-64. The pictures are very similar that we get. We've got the Octria scan. We don't use that anymore. If someone comes to me and they've got an Octria scan, I send them for a dotatate, just because it's such better quality. So at Vanderbilt, we have primarily been using the copper-64 now, primarily for logistical reasons. So it gives very, very nice pictures and very user-friendly. And so what we look for is those tumors that have receptors that light up when we look at the pictures. But sometimes, yes, so things like arthritic changes can sometimes also fool us. So not everything that lights up on that scan represents a malignancy. So even if you look at, I always look at when patients are with me, I always pull up their scans and we go through, their scans from head to toe. And I point out, all right, this is normal, not everything that's lighting up is abnormal here, but all right, here's your abnormal stuff. But things like, you'll see things light up in the spleen or sometimes in the pancreas or kidneys and the bladder. This is all, these are all normal.
Got it. Thank you so much.
If there's a problem, we talk about it at our tumor board with our new med colleagues, with our radiologists. Sometimes we get fooled and say, all right, well, if something's kind of lighting up in a bone and we're not sure, we'll get an MRI, and that'll solve it.
Thank you so much. Next question is from Kimmy. It says, is it okay to have specialty chiropractic work done? I'm curious if problems with arthritic degeneration and a torque misalignment at the base of the skull causing a narrowing of the neural canal could cause this cancer, or I'll say could impact this cancer in some way, or maybe cause the receptors not to recognize it to fight it off.
So when you're talking about skeletal manipulation, I'm assuming that's what
that's fair.
The chiropractors, they do a lot of different things, and one of the things that they do is musculoskeletal manipulation. I'm actually an osteopathic physician, so in medical school I was trained how to do this. I don't do it anymore, but I think we just got to be careful in a patient with cancer, because when you're moving bones like that, sometimes if you have a malignancy in that area, those bones are weak already and they can break. So I think, making sure that's not the case before they start any manipulation, because there are cases out there, the pretty devastating cases of, albeit rare, that these things happen because an undiagnosed cancer and there's a manipulation done, and you end up with bad outcomes. So I would just be careful with that, and talk with your doctor and see what they think about it.
Another surgical question. I have an atypical carcinoid in my lung and 3 in my liver. For that situation, would surgery be most likely the best option? Or what?
So again, it depends on what the scans look like, the burden of disease. So generally in the lung, unless it's causing problems in someone with metastatic disease, we would probably leave it alone. If it's causing symptoms, sometimes we can take it out. Again, but these are all case by case kind of things. Sometimes we can, if there's 3 small liver spots, we embolize those or ablate them and get rid of them, and then go after the lung. So it really depends on the extent of the disease, and it's I'd encourage, with everybody, I think being seen at a specialty center, will go a long way, even if it's a one-time visit, just to kind of say, am I on the right track, and am I, is everything, the way it should be, or should I be thinking I need to be doing more? So I would encourage, the Carcinoid Cancer Foundation has a list of doctors by state. There's always specialty clinics around. Certainly, if you email me, I can, tell me where you're at, and I can make a recommendation if I know someone in that area. But I think that specialty opinion goes a long way. And we, and even with us and with all of the other specialty centers, we work with your local docs. We realize it's hard to get all the way over here, and so we work with the local team, and the other thing, even if you can't get here, if you if you can have your doctors just pick up the phone or send an email to us and say, hey, I've got a patient here I wanted to get your opinion on. We do this every single day, so it's all about, getting the right care to patients.
Got it. Next question. I've had symptoms of carcinoid and with ipsilateral facial flushing and Horner syndrome for 3 years, but so far unable to find a tumor. Serotonin and norepinephrine only mildly elevated. What other markers, if any, could cause these symptoms?
It's hard to tell. I would say, you need a thorough workup. And whether that, certainly with scans, there's other markers that we would consider. There's the dotatate PET imaging, and what I would say is, maybe it's not a carcinoid tumor, which would be great. And I see this all the time where patients will get referred to me for symptoms or an elevated chromogranin, for instance. And it's always a good day when I can say, I don't think your symptoms are related to cancer. So.
Right on. Question from Jim. Do most people with carcinoid cancer probably have lung nets, but too microscopic to detect?
Interesting question. I don't.
So too.
Yeah, I don't know. I guess it's I wouldn't say most. I mean, I think, at some point these things will declare themselves, so, but certainly any of these, neuroendocrine tumors, they can certainly spread to the lungs. So it's an interesting question. And that, that does, tell us something though, that, we're only as good as what we can see on our scans or detect on our labs. So there may be things underneath the surface that we can't see, and that's one of the reasons that we follow people for so long. And so sometimes from here on out, we don't let them go, even if they're NED.
Thank you so much for your question. Appreciate it, Dr. Ramirez. Next question from John, who's usually here on behalf of his wife. Hello, John. Good to see you. My wife has carcinoid syndrome, which we found back in February. She gets her lanreotide injection every 28 days. We're into 9 months now. Are there any tests we should ask for or mention? I understand everyone is different. She has blood work fairly often. Does that tell us enough of how things are going? It started in the bowel, then to the liver, then to the heart. They're planning on replacing 2 valves in the right side in a couple of months. So any other thing, John's always here being diligent, trying to be a great advocate.
Yeah, that's great. Thanks for that question. So yeah, I mean, there's certain workup with, if it's only on, if the treatment is only lanreotide, which is great. It means things are otherwise stable. So normally with the small bowel tumors, we think about getting a 5-HIA, a serotonin, a pancreastatin. Some centers will measure a neurokinin A. We monitor the heart valves as well. So with yearly echoes. So it sounds like there's a carcinoid heart disease and valve replacement. And I think that's one of the biggest things is monitoring that. And we've had patients come through with horrible carcinoid heart disease because of this elevated serotonin, because of a high tumor burden, but their symptoms are all related to the heart disease. And so we fix the heart valves first, and then we can go back and kind of take care of everything else, and we can really improve that those symptoms. We've had patients in the past. One in particular I can think about was in New Orleans, horrible heart failure syndrome, and had a significant burden of disease within the liver and small bowel. But her symptoms were all related to heart failure. Couldn't walk, very edematous, horrible shortness of breath. And she saw a heart specialist and who told her, well, no, you've got cancer. I can't operate on your heart. And she came to us and we essentially said, no, we need to fix your heart first before we can tackle the cancer. And so we sent her to somebody who did take care of her, and she came back looking like $1 million, and we were able to, take care of her after that. But yeah, I mean, you've got to really kind of triage, these, what's most important here.
Understood. Thanks for your question, John. Good to see your name again. From Jesse, what if you have both tumors with receptors and tumors without receptors? Does that change treatment options or plans? And a few other people have this question as well.
Yes. Occasionally we'll see this, and yeah, it's sometimes a conundrum how best to proceed with that. So I mentioned PRRT is a mainstay of what we do, but if you have receptors in the lung but no receptors in the liver, will PRRT be effective for you? Well, the answer is it's not going to be effective for the liver, but it may be effective for someplace else where you do have receptors. So, it depends on the burden of disease. So if we can do some local treatment to the area where there's no receptors, maybe we can come back with PRRT afterwards. So maybe it's some chemotherapy and kind of see how things go. So there's I think there's options either way with these, but we certainly see that from time to time.
Got it. Thanks, Jesse. Next question from Dawn. And folks, I just want to say, if you are new to the show and don't know me, I'm not a medical expert. I'm just the moderator here, the host, the conduit to give you all this information. So I get to learn a lot too from these programs. And so this next question, don't judge me, is what I'm saying. Dawn asks, can ground glass nodules be a NET? Now, I'm unfamiliar with that. I can look things up, but I like to learn here from our experts as well. So that's the question, Dr. Ramirez. Can ground glass nodules be a NET? And there's 5 other people that have that question. Can we establish what those are first and then try to take that question?
Yeah, so ground glass nodules are we see pretty regularly actually when we look at scans, and so it's not just a nodule. People can say the scan has a ground glass appearance, and so what it is it's when you look at the scan, when the radiologist is reading this, there's a characteristic finding that they see, and it appears like ground glass. So you take glass and you grind it up, and that's what it'll look like. Now, usually these don't represent cancer. They can represent some sort of inflammation or infection. So normally what we see when we think about cancer is a solid nodule. And then, again, sometimes we see, we'll see a finding that says the left lower lobe has a ground glass appearance, but that's normally consistent with an inflammatory type process, not necessarily cancer. But again, it's something that we always monitor. So if we see that, what we want to do is follow up on it. We don't ignore it and say, all right, well, that's nothing. We follow up on it and we say, all right, well, let's get another scan on you in another few months, or let's treat whatever infection or inflammation may be going on. And then if it doesn't get better, if things are getting worse, normally these things declare themselves. Well, then we may need a biopsy or some other intervention there.
I understand. It's kind of like I went to the dentist recently and he saw like a shadow on my tooth, and he's like, I don't think that's a cavity, but we're going to check back next time. And if it has grown or it's more definitive, then we can understand. Okay. Thank you for that. And thank you for your question. Hopefully that got some clarity. We're moving on. Gene from Elon, North Carolina, right up the road from me here in Durham. Why? And we mentioned the pill cam already. So this is why I asked this question. Why are doctors reluctant to use the pill cam? I begged for it for years, but no one would do it. So how small of a tumor would a pill cam be able to see? Is that what might prevent it from being used?
So I guess I guess this is a question more for the gastroenterologist. It's not 100%, with the pill cams. Pill cams can miss things. So yeah, I think, discussing that with your GI doc, normally we start out with colonoscopy and EGDs and the upper and lower scopes. And if we don't find anything, then, normally the next step is a pill cam. So I'm not sure why, folks would be reluctant. I mean, it's, unless they just don't do a whole lot of it, but certainly I'm sure you could find a center that would do this.
Got it. Thanks, Dr. Ramirez. Next question from Tyler. What affects the grade of the tumor? A few people have this question as well. If it was undetected for years, can the grade change, like low grade to intermediate?
Yeah, that's a great question. Sometimes, the grades of neuroendocrine tumors, we break them into 3 different grades, 1, 2, and 3, and then within the grade 3, we break that into a well-differentiated tumor versus a poorly differentiated tumor. So very aggressive. So yeah, the grade can change over time. It doesn't happen to everybody, but every now and again, we'll see patients who've been doing very well with their low grade carcinoid tumor for many years, and then all of a sudden they have the development of new disease. And many times what we do is we repeat a biopsy on patients if something doesn't look right. And every now and again, we'll see that grade go from a grade 1 to a grade 2, or a grade 2 to a grade 3. So yeah, it can change over time, but that's why, that's one of the reasons, we watch you so closely.
Got it. Thanks. Dr. Ramirez, Karen says that you are not going to Key West. In fact, Vanderbilt is so lucky and smart to have recruited Dr. Ramirez. I have to agree, Karen. Question from Dawn and a few other people. Could a paraganglinoma cause carcinoid symptoms?
So a paraganglioma, yeah. So you can have symptoms similar to this with, typically with those types of cancers, we see the catecholamine release with elevation of blood pressure, but certainly you can run into some of those things. I don't necessarily see the diarrhea, but certainly sometimes some flushing. But yeah, that's another type of neuroendocrine tumor that we treat a little bit differently, but there's more and more data and more research in that realm as well. So we've even got some clinical trials here that are specific for paraganglioma or pheochromocytoma. So I think that, another uncommon neuroendocrine tumor, but I think there's more and more things coming down the pipeline for that.
Got it. Folks, we got just shy of 10 minutes left. We're going to keep pushing forward and trying to get as many questions as we can in while we have Dr. Ramirez. Jesse says, I was told a single tumor could not be removed from the lung, but the whole lobe would have to be removed. Is this true?
So I think they can it depends. So one, it depends on where the tumor is located, how big it is, and what the extent of operation would need to be to have clear margins with no tumor left behind, because that's the whole goal. If you can take out the entire tumor, that's great. If you leave cancer behind, you might as well not even have done the operation when you were talking about lung. But to be oncologically sound, it's usually the gold standard is to take the entire lobe with the surrounding lymph nodes. Now, there's some data for the typical carcinoid tumors where you can take less than a lobe. So it's something called a segmentectomy. So each lobe has certain segments. So if you can take out that segment that the tumor is in, well, maybe that is equivalent to taking the whole lobe. Now, again, it really depends on the size of the tumor. Has this spread to any of the lymph nodes? Where in relation to the bronchial tubes is this? So I am a big advocate for being seen by a dedicated thoracic surgeon. So someone who does a lot of lung cancer surgeries. And they should be able to tell you exactly what they're able to do. What we try not to do are what are called wedge resections, and that's exactly what you're describing, is just taking just taking that tumor out without doing that formal cancer operation. So so it's really important to talk with somebody who is a dedicated thoracic surgical oncologist.
Got it. Thank you for that. This next question, Dr. Ramirez, I believe, well, I know that you can field this question, but I believe the patient that I met of yours, this may be of what she had, but how rare is Cushing syndrome over carcinoid syndrome with lung nets? Am I accurate in the
Yes,
yeah, okay.
yes.
So talk to us about Cushing syndrome.
Yeah. So Rain, you met one of our patients with this entity. It is really uncommon. It's not something we see a whole lot. I mean, maybe I'll get a patient once a year with this, and so it's pretty rare, but you certainly see it. And you recognize it, and as you met my patient previously, it caused a lot of problems before a diagnosis. So but once you get that diagnosis, and you can take care of it, and it really can be life-changing.
Got it. A few more minutes left, folks. I see somebody asked for your email again, but just to that person, we included that in the comment section so that Dr. Ramirez, so you can contact him. And folks, there's also been some very, very case-specific questions asked today that were very, very long. And so for those, I say take them to Dr. Ramirez. Unfortunately, in this format, we specifically can't go too deep into very specific cases. So that's what I would encourage you to do. He's been gracious enough to give out that email. And again, we have put that in the show notes. Dr. Ramirez, you mentioned earlier about the copper 64 scan and how Vanderbilt is using that often, I think you said, right?
Mm-hmm.
So this is fairly new from my understanding, because many of the people we talk to, or the institutions, that they work at, may not have the same amount of experience with it. Is that fair to say? Like some places are starting to implement it more than others?
I think it's an easier test to do. So,
okay.
So the way there's not a special gallium scanner. There's not a special copper scanner. It's a PET scan. Mm-hmm. So in the gallium and the copper are what is injected into you. So any place with a PET scanner can do this. So with gallium, it needs to be made locally, because the half-life of gallium is very short. Okay, mm-hmm. So you can only make so many doses per day, and it gets shipped out to wherever the patient is. So here in Nashville, we can make it, and if we've got people who need it, here we can do 3 scans a day. But because that half-life is so short, if there's a delay for whatever reason, patient, if their car breaks down or they're running late, that gallium goes away. Once it's, you can't use it anymore. Mm-hmm. So the difference is the copper has a much longer half-life. So we've got all day to use it. And so this is actually made in St. Louis. And so it can get shipped to whatever facility you want to do it at. So even though, so in Nashville, for instance, we've got that generator where we can make gallium, but maybe they don't have that, down the road, in middle Tennessee. But maybe they have a PET scan and they can do copper over there. So it just depends on what you're set up to do. So yeah, I think, for us, we made the transition to copper just because it's a little more forgiving in that aspect. We're seeing a little bit of differences where in the scans and picking up things that maybe we weren't seeing on previously, but it may have been there before. So I think there's more to the copper story, that we'll be hearing about. But yeah, it's great to have the options here.
Awesome. I think one more question. This is from Bernard, our friend. I believe you're from Kenya, right, Bernard? Good to see you again. Bernard and a few other people have a question. Do nets cause dryness of the skin? I know we talk a lot about flushing. Do they cause dryness of the skin, to your knowledge?
Not to my knowledge that, I mean, certainly things overlap. You know, I think certainly sometimes some of the treatments that we use can cause some skin toxicities as well. So I think, you know, those are all things that I would be looking at as well. You know, you know, this is one of those things where if I can't figure it out, I'll send to my dermatology colleagues and say, hey, is there something else going on here?
Yeah, it truly takes a team. And I will say that I've learned that too through this show, that sometimes it's the disease, sometimes it's the treatments that cause some of these symptoms. So fair point. Okay, folks, that's the hour. Our time with Dr. Ramirez for today is done. I have a hunch that we may see him again, but he's always there or thereabouts. And we appreciate you so much, Dr. Ramirez. It's really great to see you again.
Great seeing you. Thanks for having me. It's been fun.
Absolutely. And thanks for you at home, as always, for joining us. And we hope this program helped answer some of your questions. And I'll always reiterate, just reach out to CCF, either at carcinoid.org or here on the Facebook channel. You can also reach out to our guest who has provided his email today. Thanks again to our presenting sponsor, Ipsen Biopharmaceuticals, because without them, this program wouldn't be possible. And finally, my name is Rain Bennett. I have been your host. Thank you for watching. Please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everybody. Bye.